Well, good morning, everybody. My name is Christoph Stremicus, and I'm the Director of the Market Analysis and Insight Program at the California Healthcare Foundation. CHCF is an independent, nonprofit philanthropy dedicated to meaningful, measurable improvement in the healthcare delivery system here in California. Today is an exciting day for us at the Foundation as we release another study from our signature Regional Market Report series. Our regional market reports are in-depth studies of 7 diverse areas that reflect the range of socioeconomic, care delivery, and financing conditions that we have here in California. You can find the report that we're going to talk about today, which is focused on Los Angeles County, and all the collateral from this webinar on our website at chcf.org. We'll continue to release regional market reports and conduct webinars like this through the early spring. We're really fortunate today to have the lead author of the Los Angeles report, Jill Yegian, here to briefly highlight her findings. We're also joined by the impressive group of local healthcare leaders that you see on your screen here. Each is here to talk about the unique challenges and opportunities that they're seeing from their perspective in Los Angeles County. 2 very brief housekeeping items before I turn things over to Jill. First, please do take advantage of our panel's expertise. Enter any questions that you have throughout the webinar into the Q&A box at any time in the next hour. After each panelist has had a chance to speak, my colleague Lisa and I will moderate and ask just as many of your questions as we can. Second, please do take a minute when the webinar concludes to fill out the evaluation that's going to pop up on your screen. It'll just take a second, and I can tell you your feedback is really valuable and helps us with our future programming. So with that, let's get started. It's a great pleasure to turn things over to Jill Yegian, principal at Yegian Health Insights and lead author of the Regional Market Report on Los Angeles County. Jill, can you unmute yourself, turn your camera on, and get things kicked off for us?
Absolutely, Christoph. Thank you. And it's really a pleasure to be here and to have an opportunity to share some of the key findings of the Los Angeles Regional Market Study. Next. I wanted to start with the approach and information sources. As Christoph mentioned, the study is intended to tell the story of several distinctive markets within the state of California. And to do that, we couple qualitative and quantitative data. For the LA project, we interviewed 30 regional leaders from plans, providers, government, and community. And we coupled that with analysis of an array of quantitative data sources and a scan of news, journal articles, and other sources on the Los Angeles healthcare market. This project did start before the COVID pandemic. So while we were able to incorporate some key aspects of how the pandemic is playing out in Los Angeles, it is absolutely not a study of COVID in LA. And last but not least, I want to really acknowledge my co-author, the fabulous Katrina Connolly from the Blue Sky Consulting Group and the whole Blue Sky team. Next. So let's begin with some market background for Los Angeles County. Los Angeles is huge. 10 million residents, a quarter of the state's population. In the title, we say vast and varied because that really does capture LA County. 88 cities, some very densely populated areas of the state, coupled with sparsely populated areas. There's coast, there's mountains, valleys. It's really quite a varied and diverse county. That's true in terms of the population demographics as well. And when we look at the county population compared to the state as a whole, there are some key distinctions. One of them, and you can see the pie charts on the upper left, is with regard to race and ethnicity. This infographic, by the way, comes from the quick reference guide that CHCF published. In Los Angeles County, about almost half of the population is Latinx and about a quarter is white. And that is a quite different distribution than the state as a whole, where we see a much more even split at 37 to 39% for each of those groups. The health insurance profile is quite different as well. As you see in the bottom left pies, fully a third of the population of LA County has Medi-Cal coverage and 10% is uninsured. And those are both figures that are higher than the statewide numbers. The economic indicators also reveal that in Los Angeles County, residents tend to be lower income. There's a higher unemployment rate, that's pre-pandemic, and more difficulty being able to afford a median priced home. Next. The statewide statistics mask tremendous variation within Los Angeles County with respect to economic and healthcare indicators. Both this map and the table are available in the report. Los Angeles is organized into 8 different service planning areas or SPAs, and they vary quite dramatically with respect to geography, demographics, health status, and other features. For the purpose of just highlighting some of the distinctions and indeed disparities among the SPAs in LA County, we would just note that SPA 4, the Metro SPA, that is where the city of LA is, the downtown area. SPA 5, the west, is the coastal region. That includes, for example, Santa Monica. SPA 6 is the south. That is an area that includes cities of Compton and Linwood. And when we look at SPA 6 in particular relative to 4 and 5, we see, for example, in the third row down, that over 40% of residents report an income that is below 100% of the federal poverty level, compared to 20% for SPA 4 and 10% for the West. And on down the line in terms of worse health status, more challenge obtaining doctor's appointments in a timely way, more diabetes diagnosis, and so forth. Next. If we drill down on Medi-Cal, again, a third of the population of LA County, LA's enrollment in Medi-Cal makes up 30% of the state's total Medi-Cal enrollment, with almost 4 million beneficiaries, and that's up 340,000 since 2014. Medi-Cal managed care in Los Angeles is organized as a 2-plan model. LA Care is the local initiative, and HealthNet is the commercial plan. And collectively, they enroll about 3.1 million members. There is a twist to the 2-plan model in LA, and that is partner plans. You can see on the figure on the right that LA Care delegates about 1 million of its members to Anthem, Blue Shield, Promise, and Kaiser. HealthNet delegates about 100,000, 90,000 to Molina. And those partner plans are delegated full risk for those members. In addition to those partner plan delegations, LA County Department of Health Services has full risk arrangements with both LA Care and HealthNet for about 300,000 members from both plans. LA County DHS operates integrated delivery network that includes 4 public hospitals and 27 county clinics, and takes global risk for those 300,000 members. All 6 of the plans delegate professional risk to medical groups and IPAs for most members. On the covered California side, what we see is that enrollment reached 420,000 last March. These partner plans all compete head-to-head in that marketplace, along with a couple of others. And it's worth noting that LA Care is the only Medi-Cal managed care local initiative that's participating in covered California. And actually, with enrollment of over 80,000 members, is the 4th largest plan statewide, even though enrollment is only in the county. Next. Turning to health systems, we know that consolidation is a hot topic statewide, but in Los Angeles, we have the least concentrated market of all 58 counties. We can see from the table on the right that the 6th largest health systems in LA County make up about half of the acute inpatient discharges, but only the largest share of those, no one system accounts for more than 11% of those discharges. 2 of the systems, LA County DHS and Kaiser Permanente, spread almost statewide, almost countywide. And it's almost because neither of those systems has a facility in the rural northern part of the county of Antelope Valley. We say in the title of the paper that we see inching towards consolidation due to some of the developments over the last 5 years. The Cedars-Sinai health system is affiliated now with both Torrance Memorial and Huntington. A major merger occurred between Providence and St. Joseph in LA and Orange over the last 5 years. And Providence is now focused on building out regional health networks. UCLA Health is continuing to expand its ambulatory care sites, not only across LA County, but into the neighboring counties. And on the physician side, Optum acquired DaVita Healthcare Partners and is building out an entire southern region approach, including throughout Orange, Inland Empire, and San Diego. Next. Federally qualified health systems play a significant and growing role in Los Angeles County as safety net providers. The scale is massive, over 350 sites, serving 1.7 million patients. And we've seen significant growth in the last 5 years in the neighborhood of 30% increase in sites and patients. These are primarily Medi-Cal and uninsured patients. Medi-Cal is about 61%, covers about 61% of the FQHC patients, and about 29% are uninsured. The FQHCs in LA County are many and diverse, and it's difficult to generalize about them, but collectively we can say a few things. They provide primary care services for about 140,000 uninsured people who are enrolled in LA County Department of Health Services My Health LA program. Collectively, they tend to struggle to ensure that adequate access is available to specialty care, particularly on the Medi-Cal side. There has been significant focus in the last 5 years on systems building, on increasing capacity in health information technology, quality improvement, and other systems. And we see a rapid and very successful pivot to telehealth amongst the FQHCs, though that is accompanied by concerns about the future of reimbursement for telehealth and other virtual services after the pandemic. And we heard from one of our interviewees, if you overlay a map of clinics and a map of COVID-19 inequities, they line up and the economy will make it worse. Really significant concern about the effect of the pandemic across various populations and particularly on health disparities. Next. A theme that we heard throughout our interviews was challenges with coordination and access for both patients and providers in Medi-Cal. It's a complex system to navigate. Medi-Cal managed care plans, we talked about the 6 plans, and they have oversight, responsibility for services to Medi-Cal beneficiaries. The Department of Health Services, as I noted, has responsibility for those that integrated delivery system of public hospitals and clinics, and responsibility for the care of 300,000 members. The Department of Mental Health in LA County runs a countywide specialty mental health plan for all Medi-Cal beneficiaries, not just those that have been assigned to DHS. And likewise, the Department of Public Health in Los Angeles County runs a countywide plan on the substance use treatment side, again, for all Medi-Cal beneficiaries, not just those assigned to DHS. The federally qualified health centers play a significant role on the primary care side in particular, and of course, private providers play a role throughout. Primary care, specialty care, inpatient care. And the sum of this is some complex navigation challenges for patients. We heard in particular from our interviewees about specialty care. So Medi-Cal rates are low, bureaucracy is high, it's hard to get specialists. And on behavioral health, you couldn't design something less user-friendly to consumers. Now, it's worth noting this is not specific to LA County by any means. But the scale, just the magnitude of people, population, Medi-Cal beneficiaries in LA County makes it a significant challenge. Next. LA County was hit particularly hard by COVID. Through August, the infection rate was about a third higher than we saw statewide, and a death rate 75% higher. The unemployment rate between February and August increased 3.5 times, reaching almost 50% higher than statewide. And of course, the resurgence of the pandemic in late fall created an entirely new level of challenge and crisis. There was a silver lining in terms of the growth in telehealth and the ability to really push on a technology that's been on the back burner for some time. As I mentioned, we heard significant concern about the disparate effect of the COVID on Black and Latinx populations in particular. LA County worked with the state on Project Room Key, which was a program to find motel and hotel rooms and make those available to people experiencing homelessness and at increased risk of adverse outcomes due to the pandemic. Next. And here is a list from the report of issues to track in the interest of time so that we have lots of time for our speakers rather than going through each of these. I'll turn it back over to Christoph. Needless to say, there is a tremendous amount of really exciting work going on in LA, lots of challenges, lots of market dynamics, and really want to express my appreciation to the speakers on this call for their participation in this work.
Thank you so much, Jill. There definitely is a lot going on, and we're lucky not only to have them, but you here to help sort it out a bit. So thank you for getting things kicked off. At this point, I am really excited to turn things over to our panel of local healthcare leaders for their perspective on the challenges and opportunities in the Los Angeles region. As a reminder, each panelist will provide about 5 minutes of remarks on any findings that were particularly surprising, anything that really resonated, or anything else they'd like to highlight. And as a reminder to our audience, please feel free to type any questions you have for our panelists into the Q&A box. I'll moderate just as many of those as I can after all of our panelists have had a chance to provide their initial thoughts. So at this time, I'd like to turn things over to our first panelist, John Bacchus, CEO of LA Care Health Plan. John, I see you got your camera on. Can you unmute yourself and let us know, how do things look in Los Angeles from your perspective?
Well, it's raining today, which is generally considered a relief here, but it's not adding to our joy at the moment. Well, first of all, thank you for including me, and this report is just very rich in information that's important. The thing that I want to, there are a few things I want to build on from the report. Number one, the inequality in the county is stark. And I think the data that showed that we had a higher rate of Medi-Cal participation in the county and a lot of the other economic statistics bear that in. And one thing that I want to remind listeners, when we talk about Medi-Cal enrollment, we're talking about people who really are at the lower end of the economic spectrum. Even though California goes up to 138% of the federal poverty level, for 2021, that means that an individual can't make more than $17,600, or a family of four more than $36,156. So it really is, if we've got a third of the population living under those conditions, we have a tremendous amount of inequality represented in the system. And we've seen the numbers grow. When the pandemic started, there was a big concern that we would have a sudden jump in Medi-Cal enrollment, and we have had a jump in Medi-Cal enrollment. And I can report that our enrollment now is 2,350,000, which is up considerably from the numbers that are in the report. And it's mostly because Medi-Cal suspended redeterminations. So people no longer have to, or during this emergency pandemic, they don't have to file to be redetermined that they're eligible for Medi-Cal. And while the numbers have burgeoned by a couple of 100,000 for us, we're setting ourselves up for a big problem when the pandemic emergency ends. And we're afraid that many people will suddenly get dropped from the rolls. And that may be when they're still in line to receive vaccines. So we're very concerned about that. The other thing I'd like to add is on the point about how many patients that are true safety net providers, the federally qualified health centers and the Department of Health Services take care of. You heard those numbers, and that doesn't come anywhere near the 3.3 million people that are on Medi-Cal. So what we and our partner health plans have had to do, and our competing health plans, is really broaden the network of participation of providers in Medi-Cal. So we have lots of community-based providers, lots of community hospitals that are participating, and that's how we make it work. But the more we have to reach outside of the safety net to bring people in, particularly the tertiary and quaternary health centers, we run into a basic dilemma, and that is that we don't get enough reimbursement in Medi-Cal to really engage in the way we should with those facilities. And as a result, we think we're not getting people to the right place at the right time for the right care. We're working very diligently with all of those facilities to try to find a pathway so that we can give access to those who need access. We certainly don't want to flood the specialty centers with care that we handle at community hospitals, but it is a dilemma, and it adds to our concerns about the inequality of access to healthcare. The COVID pandemic has certainly brought out these inequalities and disparities in the harshest way possible. You all know the statistics that people of color and low income are being much harder hit than other people in the community. And we see that in the data we have to deal with every day here at LA Care. So we're trying to figure out ways that we can work with the state, the county Department of Health, and others to get a more equitable distribution of the limited vaccine supply that is available right now. And it is a challenge. The early data shows that the people in most need are not getting it. So we're working with anybody that we can to make sure that that kind of thing happens. So LA County is the most diverse place I've ever worked. And it's also a strength because we have a lot of innovative people here, and everybody seems to have the desire and willingness to find common solutions to reach our most vulnerable people and give them equal access to care.
Thank you so much, John. That was just perfect. Next, it's my great pleasure to introduce Dr. Christina Golly, Director of the Los Angeles Department of Health Services. Dr. Golly, I see you have your camera on and you've got yourself unmuted. How do things look in Los Angeles from your perspective?
Thanks, Christoph, and my pleasure to be here. Thanks for having me. And I do want to extend my thanks to Jill and you and your team, as well as to Christoph and the entire CHCF team. The report is excellent. And it's nice to see Los Angeles County highlighted and try to put some structure around what really is an incredibly complex region. I want to touch on just a few points, and I won't talk about COVID because once you start down that path, it's hard to stop. But I'll touch on a few other points and then more than happy to take questions in the Q&A. One of the things that I thought was really well done and striking, and is certainly an area of challenge for all of us across Los Angeles County, is the separation and the attempt to manage patients who have both physical health and also behavioral health conditions. This is especially hard for those of us within the county and DHS. We do serve a population that is more embedded for individuals with co-occurring disorders, often have addictions as well as specialty mental health issues. They're often some of the most vulnerable populations. They may have recently come out of incarceration. We have a high rate of homeless individuals that we're caring for. And the separation of how California has structured the behavioral health system really makes it very challenging. And I think what Jill covered in the introduction is so important to both understand understand how the county, within the county, structures those services. I find oftentimes people don't really fully understand. They think that the county government health is all together. And so I appreciate the effort to really help people to understand how the three departments really do have very distinct roles. So within my department, the Department of Health Services, we are, literally the health services department. So we have the impaneled and assigned patient population that Jill mentioned, and we work to provide comprehensive care for those patients. We also are the provider of specialty mental health services on the acute inpatient psych side and the psychiatric emergency departments through a contract with the Department of Mental Health. But the care of those patients who cross lines is very challenging, because then the Department of Mental Health serves as the plan for specialty mental health for both Medicaid and then also functionally for the uninsured. And the same thing for the Department of Public Health with respect to the drug Medi-Cal program for providing coverage for individuals with substance use disorders. And that's true again for both Medicaid as well as the uninsured population. So what we end up having to manage within the Department of Health Services, and it's the same thing experienced by the FQHCs as well as all of the private providers, it's trying to take excellent care of your patients when you're working with the plan, LA Care, Health Net for Medicaid, as well as their subcontracted providers for mild to moderate mental health services, which is Beacon and MHN, and then trying to contract with the Department of Mental Health for specialty health services or send your patients out, and then also trying to do the same thing for substance use disorder. And I do believe that this is just not patient-centered and patient-friendly, and it makes care management and optimal care of the patient really incredibly complicated and unnecessarily so. We're trying to address this within DHS. We have just gotten our first drug Medi-Cal certification over the past couple of years, so we can be a provider of substance use disorder services, and we're working to expand that across the DHS network. We're trying to get contracts over time with Beacon and MHN, so we can do the same thing on the mental health side. And then at some point in the future, we'd love to get a contract with the Department of Mental Health for the provision of outpatient specialty mental health services, but that will be a longer road. Moving forward, there's lots of opportunity for improvement. And certainly, just as John mentioned a minute ago, COVID really has laid bare the stark inequalities that are experienced across populations in Los Angeles County, and those break down tragically along income levels. They break down along racial lines. And this is not something new, but it's time, long overdue time, to really try to figure out what to do about that. And I think there's a huge opportunity with the state's CalAIM program to try to move in a direction of equity and how to prioritize changes across the system that can help promote equity and adequate care for patients. There also needs to be really a focus on vulnerable populations, particularly focused on really the mass and over-incarceration of people in California and most notably in Los Angeles County. This is something that we're very focused on within the Department of Health Services, because among our other functions that haven't been touched on as much today, we also provide care for the individuals in the Los Angeles County jail system, which is over 100,000 individuals per year. And then we also operate the Office of Diversion and Reentry, which does mental health and substance use diversion for individuals who can be safely diverted out of jail for community-based treatment. And so we'd love to see an emphasis in that part of equity and how we can promote really more wholesome and comprehensive healing for patients that can both enhance the individual patient's health and also, we believe, public safety. And finally, I do think CalAIM has the opportunity to support that, not just in the programmatic structure, but in restructuring the financing lines and the financing flows, potentially trying to look at how we can better either manage those disparate lines or braid funding over time, and also how it's possible to try to put currently unmatched streams of money on the table for inclusion in the Medicaid program, so that those funds can be matched and we can seek to enhance the overall programmatic offering for patients with Medicaid. Thanks so much for having me.
Thank you so much, Dr. Golly. That was just great. Next up is Louise Mccarthy, President and CEO of the Community Clinic Association of Los Angeles County. Louise, I see you have your camera on and yourself unmuted. Take things away.
Thanks, Christoph. And just thanks to the California Healthcare Foundation. These reports are great. We really appreciate them and the role that you play in really elevating the issues that are happening at the regional level. And also, thanks for putting me after John and Dr. Golly so that they get to queue up some of the complex issues that we're dealing with here. And I can say ditto to the complexity of our systems and ditto to the issues that we have related to equity here in Los Angeles. So going into, and so we're living that same contracting melee that Dr. Golly is talking about from the health center side, and that our members contract with Dr. Golly to serve the underinsured, with DMH to provide mental health services, with DPH to provide substance use services, and it looks like a spaghetti, a lot of spaghetti when you look at how things are organized. And as we look at before going into the pandemic, health centers were already on shaky ground. So Capital Link put out a report working with CHCF late last year, looking at health centers prior to the pandemic. And after the boom of the Affordable Care Act and all of these major expansions that Jill talked about, there really was an evening off. And at the end of 2019, a quarter of the health centers in the state of California had less than 30 days cash on hand. So just putting that in the context there, so then a pandemic hits. And so despite these challenges with their finances and some of their infrastructure, being able to build it out, health centers had an agile response. And that agility, that ability to be able to turn on a dime, is something that has really been one of our benefits, because everything's been changing so constantly throughout all of this. So in looking at that agile response, as Jill mentioned, we have telehealth, the adoption of telehealth, continuing to pursue that. And also, we had already been working in the areas of social determinants of health, but the health centers really just dug in deeper. You look at distributing meals. You look at, in addition to transportation access, providing support with housing, going out and really working in the Project Room Key sites, everything they could do to better serve their communities. And so just that agile response was really critical. Now, what limited that? Well, it was certainly the cash, like I mentioned, and just having some funds. So that's why the federal government's grants through the CARES Act made a huge difference, and those PPP loans. But still, that continues and is ongoing because we have a system that isn't built to reimburse fully for care. But then a workforce as well continues to be a huge, huge challenge. We just can't find and hire the people to do this work. So I'll echo what Dr. Golly said related to CalAIM on the horizon as being one of these opportunities where we can look at these various elements of our population's needs and try to, as she say, braid these systems and these financing together, because the silos aren't helping us. And honestly, the way our system is financed isn't helping us. I think no one is being paid adequately in Medi-Cal. So I just want to put that out there. That piece around high rate of bureaucracy and low rate of reimbursement, it really detracts people from participating, in particular specialists, from our system. So looking at that financing of our system, rethinking what that's going to look like, and using the pandemic as an opportunity to rethink that too, because we know that the costs that are going to be associated with providing healthcare going forward are going to be very different. We're going to need to continue to test for some years to come. Vaccines, this isn't a one and done effort. We're going to continue to need to do that. So as we think about any place where there's a barrier or a silo or a challenge or an underfunding, we're going to have to address these if we're really going to get our hands around the issues of equity in Los Angeles. Thank you.
Thank you so much, Louise. Finally, we're privileged to have Tom Prislak, President and CEO of Cedars-Sinai Health System, with us this morning. Tom, I see you have your camera on and you're unmuted. Take things away.
Great. Thanks, Christoph. Thanks very much. And Jill, congratulations and thank you and the entire team for, from my standpoint, another great report. If there's one thing in your report that to me just strikes home is the nature of LA County as it relates to diversity in all of its dimensions. And I think that comes through in your report in multiple ways. I just begin by saying, my observations, I think, are through the lens of someone who has now for 40 years watched the Los Angeles County health delivery system evolve and watch that evolution in the context of an evolving policy environment that's occurred over that time. I think that, the report really shows how the interaction between that policy environment and the broader socioeconomic factors that are simultaneously happening in an area play out. The increase in Medi-Cal that has occurred in Los Angeles County, for example, is just one example of that. But there's also, I think, it also provides some evidence regarding how the diverse socioeconomic characteristics combined with health policy, in particular government policy, government payment policy along the lines that Louise was just describing, and how that fundamentally defines the delivery system. It does it in terms of the scale and scope of services that are available. It does it in terms of the adequacy of the facilities. It does it in things like access to specialty services that John and Louise just both spoke to. I would also share that as it relates to the delivery system, I think the report's greatest value emerges when you combine what the report shows with other information that's out there and other data points. And among other things, I think there are some things that the report combined with that information maybe calls into question, certain givens or certain assumptions that I think are driving some people's thinking about how to address things like the cost of healthcare. For example, the belief that Medicare and Medicaid payments are adequate to fund the kind of delivery system that a diverse area like Los Angeles requires, I think, has to seriously be questioned. The belief that in order to control costs, all you have to do is reduce the payment. I saw that printed somewhere recently in Los Angeles where all you have to do is reduce the payment and the cost will go down. And that's just not true. What I think the experience and the report shows is that when you simply reduce the payment, you end up reducing services, you reduce facilities, and you limit the ability for people to get the kind of care that they deserve. And finally, I think the report, together with other information, calls into question the belief that integrated delivery systems are the reason for high healthcare costs, and or that integrated delivery systems don't add value with regard to either quality or capability or accessibility to healthcare. And actually, I would suggest that that's demonstrated in a variety of ways, and it was demonstrated during the pandemic itself. In the interest of moving us on to the Q&A, which is always the most valuable, I just close by saying that going forward, and this I think is consistent with what my other colleagues have said today. In order to deal with these kind of issues, there really does need to be a reexamination of the financing system for healthcare, the payment model, which determines so much of what happens as a result of that. But then an element that I think needs a significant overhaul is the regulatory environment, the regulatory system within which healthcare operates in California. An element, frankly, that has been missing in the entire time I've been in Los Angeles is any consideration with regard to what does this all mean with regard to the delivery system. That's largely been left to the market in general. And I think that some of those questions are the kind of things that could be examined further as we move ahead. So thank you very much, Christoph.
Thank you so much, Tom, and thank you to all our presenters. At this time, this is one of the most exciting parts of the webinar for me too, Tom, and that's the Q&A with all of you. So I would ask all of our attendees to turn their cameras back on and unmute themselves. We have a number of questions coming in, and I'm going to exercise moderator's prerogative here and make sure mine gets asked. One of the common themes that I heard you all speak about was both diversity within LA County and concerns over equity. In the context of CalAIM, John, when it comes to equity, what would you prioritize as one or two things that are really important for the state to consider as that waiver gets designed?
Well, we've been in discussions with DHCS about that. But I think one of the issues around equity is just availability of providers in the places where the people who need them. And that's a constant problem. I mean, MLK Hospital did a wonderful study that showed in the catchment area for that community hospital they had a shortage of several hundred primary care doctors and specialists, and that is a huge issue. Now, telehealth is going to help us, I suppose, connect people to providers without having to transport them to the provider, but there are certainly cases where hands-on is needed. So, unfortunately, CalAIM doesn't really address that. It addresses really, to me, the value of CalAIM is that it begins to link the social services that Medi-Cal beneficiaries are entitled to into the care planning of the health plan. So we now have to assess everyone on their social determinants. We now know that Susie Smith has a food insecurity problem. The best we can do is give her a phone number or a warm transfer to go sign up for it. And what we are really trying to figure out is a way that if we identify the problem, why can't we execute the delivery of the social services that would address that? CalAIM does give us the opportunity to begin to do that, in particular through in lieu of services, where we can begin to pay for certain things that we couldn't before, or if we did before, it was like, thank you, but we're not going to put it in your cost structure. So that will begin to help. But really, rather than take Medi-Cal dollars, which are precious, and use them for food and housing, why aren't we linking the needs that we're identifying through the health plans with the resources that are already being spent on those things, and make sure we're delivering them to the beneficiaries in a synergistic and integrated way? So I'm hoping we can use CalAIM to do some demonstration of that, because that's the bigger overhaul that needs to take place, in my mind, is the integration of social services with the actual healthcare delivery.
That makes a lot of sense. Thanks, John. Dr. Golly, I hate to put you on the spot, but John mentioned workforce and the integration of social services. Are there other big priorities for you? What are your top one or two things that you're looking for in CalAIM?
Well, I think a few things, particularly related to your question around equity. It's a couple things. First, I think there needs to be better data and better tracking and better support for providing the necessary data, a good way to track social determinants of health in terms of trying to do risk-based comparisons between what the outcomes are of different populations. That's really right now missing. This was a theme, and I think Tom mentioned this most clearly, and it couldn't resonate more. I think we have to stop pretending that aligning the financing isn't necessary to be able to achieve good program integration. And I think the sooner we come to the realization that you get what you pay for. If you pay for things in a certain way, the delivery system gets structured in an according way. And you can't just make changes in the delivery structure without aligning that financing. So trying to merge streams, trying to think about what's the future of the carve-outs, trying to think about that braided funding in terms of the supports for the social services that John mentioned. And I alluded briefly to this. There is a lot of funding for housing, for food services, for homeless care programs, housing navigation services, and a lot of that money is currently not matched. And so one of the opportunities of CalAIM is that if you put that money into the Medicaid program and allow it to be matched, then you can multiply the impact of your funding. And I think that's a huge opportunity of CalAIM. I think also, again, just on the equity piece, a lot more does need to be done in terms of workforce development. There's a lot of focus on this for physicians, and I think it does apply to physicians, but applies also across the board. How can we do workforce training to help develop a future healthcare workforce that is language concordant and race concordant with the population that they'll serve? How do we invest in early medical education programs to help enhance and increase the number of providers of color, nurses of color, individuals of color who are working in the healthcare workforce? And I know LA Care has done a lot of work in that regard to try to help identify people and onboard and do loan repayment, which is exceptional. But how can we do even more to try to encourage people to go into those health professions early on and help recruit diverse medical school classes?
Thank you. Thank you so much. Louise, do you have any perspective, specifically when it comes to equity? It's something that came up for you too and your members. What are your What are your top 1 or 2 priorities for CalAIM when it comes to equity?
Well, in part, thinking about equity, if a third of Angelenos are on Medi-Cal, Medi-Cal matters. It matters more in LA than in any other county in the state. So as we think about the impact of any of these programs, Medi-Cal drives healthcare policy for many of us, given that it's the majority of our payer source. So as far as advancing equity, absolutely the jobs. And I'm really happy to see Dr. Golly talk about more than doctors. It's really great to hear doctors say we need a whole system. So I really appreciate that. But we need to look at the data from health homes and whole person care. We've participated in these programs. What did we learn? How can we do it better? What other investments need to be made? What barriers need to be cut down? We need networks, and they need to be navigable. So unfortunately, every time we get a new program, we add another IT system, and the health centers have to do multiple systems for multiple programs. So really thinking about aligning, if every health plan chooses a different metric or what they're going to pursue for in lieu of services, it's going to be really confusing at the health center level to try to navigate all of these multiple networks. And then just really, doubling down on that piece around jobs. We can't create this access if we don't have the people to do it. But for every provider that's hired, we are able to create jobs for additional staff within the health center. And that's soup to nuts, from scheduling to billing and beyond. And honestly, healthcare was before and will continue to be one of the largest job sectors for growth in LA, in particular for middle skill jobs, which is a place where you can really begin to advance equity.
Thank you so much. And John, we'll give you the last word on this one. Are there specific initiatives or priorities for Cedars when it comes to diversity, things you're really excited about in the coming years here?
Is that for John or Tom?
Tom.
Well, actually, yes. The short answer is yes. I mean, we have a significant community benefit program that includes everything from the direct delivery of services to working together with the FQHCs in various regions around the area with direct funding and programmatic support and skill building for the people who are leading those organizations. So we have a number of initiatives in that regard. And I think there are also I think what would also help from a hospital standpoint in general is clarity and understanding that the efforts that institutions make with regard to addressing social determinants, working on their own, working with other facilities in the area, and working with the public healthcare system are a legitimate element of an organization's community benefit. The community benefit is not simply the provision of free and part pay care. That's a part of it. But there needs to be a clear understanding that the engagement by the not-for-profit hospitals in particular in the social determinants is something that will be recognized as part of their community benefit.
Thank you so much. Well, I know we have a number of questions that have come in over the past hour. Lisa, can you get us started?
Yes, there's a really practical question here, since you've all highlighted where the system needs to go. But in the meantime, we have as Louise Mccarthy said, a spaghetti of services, eligibility, and choices. So how are you all working with people, with patients, with the community to make this spaghetti of systems more understandable so that they can enter, access, and get help from the system that we currently have?
Thanks for that. And I'll just say, we see ourselves as a conduit and an integrator. So that spaghetti, that's our mess. That shouldn't be the patient's mess. That should not be their mess. That should be completely invisible to them. However, us on the background, it'd be nice if it was simpler as well. So really thinking to how can we as systems integrate better so that they're more navigable for the patients. And especially if you're sending someone out, you need to know that referral got closed. You need to be able to follow up with them. And additionally, I'll just follow through with one of John's favorite topics is we got to ease up on all the care navigators, managers, coordinators, in that these patients can't have 17 people calling them to coordinate. They need one. Really, we got to get simpler on that because the coordinators are not coordinated.
Glad you've been listening, Louise.
John, do you want to weigh in on that? Some specific initiatives around helping patients navigate this spaghetti without, kind of throwing too many cooks in the kitchen, helping?
Well, I think the whole person care program is, I think, where we saw evidence that we had too many care managers trying to handle the same person, and the person gets into care manager fatigue and says, stop calling me. In health homes, it's been a little more coordinated because you do have community-based entities working in this, and there are community health workers. And in health homes, I think we're seeing a little bit more of the kind of coordination we'd like to see, where there is one principal contact with the beneficiary who then opens the door to a whole host of other services. And there may be a dozen people behind that person, but we get more engagement from the beneficiary if they have one contact they can learn to trust. And I think we're seeing more of that in health homes than we saw in whole person care. So that means as we go into CalAIM with the enhanced care management, I think we will begin to see that. But it's a reflection of the multiple layers and fractured delivery system we have in the county. And I think it's incumbent on us that are players in the county to figure out a way to integrate that, because we're all wasting resources if we don't. And I think CalAIM will give us, through enhanced care management, will give us a platform to demonstrate that we can do that.
Thanks so much. We have so many questions. I'd love to get to as many as we can. Lisa, is there? Can you give us the next one?
Yeah, there's an interesting one here from a woman who says she's a psychiatrist with the Department of Mental Health, working with pregnant and postpartum women. And one of the biggest day-to-day obstacles is lack of an integrated electronic medical record between DHS, DMH, and DPH, let alone the FQHCs. Any possibility of moving toward this?
Dr. Golly, do you have some thoughts on that one?
Yeah, I can start that. So the Department of Health Services, our EHR is a Cerner EHR. And that is currently in place within the DHS hospitals and clinics, and it is also in place in the non-substance use network for the DPH clinics. So DPH, Department of Public Health, also does provide some other clinical services that we haven't touched on a lot here. So they are on an integrated EHR. It's not been possible, we did look at this, to have the substance use disorder network or the specialty mental health network use the same platform, because those are, again, plans. They aren't so much providers. And they need a different structure for billing and claiming and contracting. And so both the Cerner system wasn't capable of supporting what the plan functions were needed, nor vice versa for the system that is used by the Substance Use Disorder Network and by the Specialty Mental Health Network. But again, really the distinction there is because they're a plan versus us as a provider. Department of Mental Health does provide some directly operated specialty mental health services, but they've opted to remain integrated on their one EHR along with their plan. And then I see the question also does comment on the lack of an integrated system with the jails, CRDF here, as well as the other jails. And that is something that we are resolving. We will go live in the jails on our existing EHR within the next year. So we will now, or in the future, in the near future, be on an integrated EHR for the individuals in the LA County jail system, the same one as is in DHS.
Can I just throw in a comment here?
Oh, he's going to say the same thing I will. So go ahead, John.
Well, no, ladies first.
The LA Network for Enhanced Services is the Health Information Exchange for Los Angeles County, and that is the layer that is meant to connect all of these different EHRs, that entities across hospitals, health centers, public, private, and that is the path to getting better information sharing across our systems, rather than trying to pull out and implement all new EHRs. Did I cover it, John?
That's exactly what I was going to say. So Lanes is a nascent opportunity for us to bridge that gap. And I'm on the board of that now. And it's in its.
Whoops, looks like
He's saying that it's in its infancy, but it's coming online and it's getting better. And we are bringing more providers on to work in the system.
But between LA Care and Los Angeles County, we put millions. Enough said.
Yeah, no, it's a great point. And I, DHS is a big participant in Lanes, and I would love it if every FQHC and private provider and hospital got onto lanes because it would allow the information sharing that's needed, even if everyone's not on the same EHR.
And Tom, do you have any perspective when it comes to interoperable data exchange, within and outside of Cedars-Sinai Health System? What is your perspective on that? Is your system getting the data it needs and able to transmit data out of the system efficiently?
Yeah, well, certainly within the system, and many of the institutions in Los Angeles make use of the Epic system, and Epic itself has a mechanism within the Epic system for a lot of data sharing. But the kind of connections that we're talking about here really would require the layer that I'm hearing described with regard to lanes, and is the kind of place where I think time and effort to see how we can make that, how we can optimize that might be worthwhile.
Thank you so much. I think we just have time for one more question. Lisa, is there one more that we can squeeze in here?
I think there are a bunch of questions related to COVID. How, in particular, preparing for the upcoming surge of the population of people who will have long-term health consequences from COVID.
Christoph, if I could, I'll just make the observation. This will be a significant latent issue for the healthcare system. On any given day today, I can tell you we have 70 to 80 people here at Cedars-Sinai who are essentially recovered COVID patients who are experiencing some follow-on problem of some sort, usually to one of the underlying comorbidities they had that made them so vulnerable in the first place. And that number is only going to grow.
Can I just add really briefly on that point? Absolutely, we're experiencing the same thing, and it will require more providers, therapists, respiratory therapists, pulmonologists, primary care. But one of the problems right now is that there's not an ICD-10 code to track this. So we can't even begin to understand what the size of the problem is. Right now, there's only a code for COVID. There's not a code for the after effects of COVID. And so there's no systematic way to begin to understand how large this problem is.
Thank you all. I think on that note, we're unfortunately going to have to call it. Just two very quick things for members of the audience. The report, the slides, a recording of this webinar, which several folks have asked throughout the past hour, that'll all be available on chcf.org in the coming days. And second, please do fill out that evaluation that's going to pop up on your screen when we wrap here. With that, thank you to our panelists. Thank you, Karen, Angie, Scott, everyone for the work behind the scenes. And thank you, everyone in the audience, for joining us today. Thank you, everyone. Have a great day.
Thank you.